Hello and welcome to today's webinar, Trauma is the Public Health Issue of Our Time. I'm Caroline Gumpenberger and I will be the moderator for this webinar, which is presented by the National Healthcare for the Homeless Council and the Coldspring Center for Social and Health Innovation, with support from the Health Resources and Services Administration, Office of National Assistance and Special Populations. This session is being recorded. This is a 90-minute presentation with the last 30 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenter for written responses after the webinar. If you are having technical issues, you may also call the Council's office at area code 615-226-2292 and speak with Lori Hopper, who will assist you. Our presenter today is Matt Bennett, Chief Innovation Officer at the Coldspring Center for Social and Health Innovation. Matt specializes in the development of trauma-informed care, quality improvement, and results-based leadership and clinical practices. As a dynamic trainer, Matt's expertise has taken him around the country speaking on topics such as trauma, leadership, quality improvement, motivational interviewing, and resiliency. Thank you, and now we'll turn it over to Matt.
Thanks, Caroline. Welcome back for most of you. If you weren't here last time, my name is Matt Bennett. Again, I'm from the Coldspring Center and get to basically continue to share my passion with you all. Had really great conversations both in the Q&A last time, and also I got a lot of emails from folks following up, and that's always a great thing to remain in contact and offer myself out there as a resource in any way I can and continue this great partnership with the National Council. So if you don't know me, I do have a blog that talks in a lot more detail about this. We'll put this up at the end as well, but it's well-named Matt's Mumbling blog there in the blue. And that allows us to go into a lot more details around some of these subjects. So if you're interested and to continue your learning, I just want to throw out there at the beginning that's a resource that a lot of people find useful in their journey to become trauma-informed. So we're going to pick up on the goals that we had last time, and if you weren't able to join us last time, I know that the recording of the webinar is available on the Council's website. In addition, I hope to not connect the dots a little bit so you don't feel lost as well, while not boring anybody that was at the first webinar. So to continue with our goals, again, these are the big goals of our four-part series here, is to really get this understanding of the impact of trauma and neurobiology and how this really informs our approaches and our understandings of homelessness and the challenges that a lot of our patients and clients face, putting those in a scientific perspective. Hopefully, if we can do that successfully, we can design programs, interventions, and services to really help folks live the life that they want to live, that ultimate goal of post-traumatic growth. Also, we want to utilize the knowledge to address the biopsychosocial needs of those experiencing homelessness. And that the final one is to really start to utilize our expertise as healthcare for the homeless providers to really address the homelessness crisis and maybe a new way in our own advocacy. So again, my goal throughout this series is to give you words, language, and concepts, not only for your own learning, which is important, but also hopefully that you can take into your roles as leaders and advocates within your community. As we talked about in the last training, the science really gives us a different way to talk about some of these societal issues in a way that I think gives us additional scientific, moral, and economic justification to really end homelessness and a lot of the other issues impacting the folks we care so much about that are in our services. The series today we're at number 2 to talk, the topic is trauma is the public health issue of our time. And we'll look about the science and really more from a medical biological perspective, though it's getting harder and harder to really separate medical health from mental health. And so we'll talk about, how that crosses over. Also, we take a week off and then we come back with looking especially at addiction, homelessness, and trauma, and how trauma can really set up the brain. If you haven't seen the research around trauma and addiction, it's a really powerful explanation of why, for so many of our folks experiencing homelessness, addiction is another struggle that they're challenged with. We'll also talk about things about like how trauma impacts our personal narratives, views of ourselves, relationships in the world as well. All this really sets the foundation for the last training on November 2nd, which looks at how do we help folks heal, that ultimate goal of post-traumatic growth. So they transform the pain and suffering of trauma into wisdom, strength, and resiliency. So what we're going to cover today in the hour that we have together is why is trauma the number one issue in public health? And I hope you walk away with this with the justification behind this title, and looking at as I listen and I'm in workshops and in conferences with more and more people in leadership roles in HRSA or state level, I'm hearing these words said by people with a lot of expertise, a lot of training, and a lot of power over the systems they operate. And so we're hearing this more and more. I hope to give some real science and justification around the true impact of trauma and how that walks in sometimes and manifests itself in both medical and mental health issues. Utilize the science to better conceptualize the root causes of a lot of the disease and social problems that we see. And then finally help, as we talked about re-traumatization last time, how do we, on one hand, assess for trauma, become trauma-informed without re-traumatizing the folks we worked with, or bringing back memories of past pain and suffering? So always a tough balancing act. So we'll speak a little bit of that as well as we go through the presentation part of our 90 minutes together here. So when we talk about adverse childhood experiences in public health, you really have to start with the adverse childhood experience study. And more and more, I remember about 10 years ago, I would ask rooms of people, how many people have heard of the ACE study? And maybe one or two hands would go up. And as time has gone by, this has worked its way more and more into the consciousness of providers and in larger society as well. But if you haven't, whether you've seen the ACE study or not, I really use it to really put forth a paradigm shift of trauma-informed care, especially from that public health perspective. And so when we look at the adverse childhood experience pyramid, what we see is a study that was started in the mid-90s by Kaiser Permanente, a large healthcare provider in San Diego, California. And several doctors and health professionals were running an obesity study. And the people, especially the women in the study, were actually being very successful. And they were losing weight. They were having success in the program. The interventions were being shown effective. And then there was a portion of the study population that just started to drop out, even though they were being extremely successful in the program. And because they were in the Kaiser system, these physicians and medical professionals that were running this program had their information. And so they reached out to these women and said, okay, what happened? Because if you're on this call, you don't want to lose your good outcomes. We want to cherish those, write those up, put those in our reports, all that. And so they reached out to these folks, and over what they heard back from these women is, when I lost a certain amount of weight, men started to pay attention to me again, and it brought back my feelings and memories of my past abuse. And that really opened the eyes of the professionals working with this. And I give them a whole lot of credit, is they kind of stuck with this. And they, at the time in the mid-90s, and I was in graduate school back in the mid-90s when this was happening, we didn't really get taught that past suffering led to current problems. And to say those words now in 2016 seems a little odd, but we didn't have that. There wasn't that awareness. There wasn't any real concrete evidence at a big scale. And so they took this and said, okay, how is this impacting the rest of our patient population? And so over the next period of time, they actually did what's called the Adverse Studyhood Experience questionnaire with 17,000 folks within the Kaiser Permanente system in San Diego. Just a little bit of input on this population, because I think it's important. Is this was not the population that walks through the health centers that I work with in San Diego, the healthcare for the homeless providers. 2/3 of this population had some college. I think it's actually 73% had some college experience, highly Caucasian. At the time, if you had Kaiser Permanente, you were likely to be getting insurance through your employer. So this was more of a middle upper class section of San Diego. So not folks like I know a lot of you work with that are struggling with sometimes very extreme poverty and homelessness. And so they started to look at this and study this, and they found a few things that really started to change, I think, our whole foundation of public health, psychology, and now that's starting to look at things like education and a lot of things different. And so at the same time, when the Adverse Childhood Experience Study was coming about, we also, for the first time, thanks to functional MRIs, were able to look into the brain and see it operating at the same time. So on one hand, we were getting this information about how past challenges and pain and suffering and trauma were influencing current behaviors, and we also were able to see the brain and start to compare the outcomes of the ACE study with what we were seeing in the brain scans of folks who experienced these adverse childhood experiences or childhood traumas. And so what we started to see was the brain that we talked about, and we'll review again and add a little bit to more, with that overactive amygdala, underactive prefrontal cortex, smaller in size hippocampus. So we saw that people who, again, had not had a chance to really work through and resolve their childhood trauma had a different physical structure of their brain. Again, even in those higher level, middle, upper class populations that had Kaiser that were being studied. And so we had this underlying neurodevelopment, and then the pyramid goes up to, that really leads, again, no fault of the individuals, but because they experienced this past suffering, abuse and neglect and family dysfunction, there was this social, emotional, and cognitive impairment that really led to the adaptation of health risk behavior. And so things like smoking, drug use, falling into things like domestic violence relationships. We'll talk about some of the medical impacts, a whole range of mental health pieces as well. And then finally, this manifests itself, especially in the medical arena, as disease, disability, and also social problems as well. Higher rates of incarceration, unemployment, housing instability, so on and so forth. And as we'll talk about, we now actually have really good proof of how childhood trauma really decreases the length of life, not only the quality of life, but also the length of life as well. And so this really gave us early on in the trauma movement, this was my introduction to it, is it really gave us a 17,000 person cohort, and really what we saw coming out of this was undeniable. And so just to talk about the ACEs and what they are, for those that haven't seen them, and these are starting to be questioned to some extent. So I'll mention what I'm seeing is probably should be included on this list, and there's conversations around this as well that I've seen started in the public health arena. But there's the abuse piece, so what we would think about the physical, emotional, sexual abuse or assault, neglect, the emotional or physical neglect. Neglect as from a therapist perspective who has worked in a lot of child welfare with kids that have experienced both abuse and neglect. I struggled originally to really comprehend why neglect was just as powerful, and in some ways it seems in the research more powerful than abuse. And in a way I could see abuse. It was something that there were bruises, that there was a physical mark from abuse, whereas neglect seemed like a very invisible thing. Even as somebody who's trained in psychology, I really had trouble equating those two to be at the same impact level. And what we know now with the research, as young children, infants, we have to reach out for others for our livelihood. we can't feed ourselves. We can't take care of ourselves. And we're just, if you've ever seen an infant, we're kind of emotional train wrecks, right? We don't have a whole lot of resiliency built up. You know, if the wind changes directions, we're probably going to cry. So we learn and we get nurtured both emotionally and physically through the availability of the caregiver. And when that caregiver isn't there, when I need the caregiver and the caregiver isn't there, what it triggers in the young child is a life or death struggle. Because if I need someone and they're not there, it seems like a life and death thing. And so this is where the abuse might not always seem that way in some ways. Neglect does, that's the experience of neglect. And so we see this as a really powerful childhood trauma. Again, I'm not going to prioritize abuse over neglect or neglect over abuse. They're all horrible things, but that's been my journey to understand the power of neglect. And then there's a household functioning as well, which I think is more and more of my thinking, because a lot of times abuse and neglect also go into that household dysfunction as well. And this was if a parent or sibling had severe mental illness, if someone was incarcerated, substance abuse and addiction, divorce, and mother treated violently. Now, the things that seem to be justifiable to include on this list are things. One of the things that I hope is changed, and you see this language starting to evolve, though I checked on the websites and they're still using it, is domestic violence can be the mother treating the father violently, and we know that there's non-traditional families as well, so with two women or two men raising a family. So that seems a little outdated. I suspect that will be updated here soon because the AIDS study is still being done in a lot of ways. Other things that we have seen and have been studied to be as powerful as these things is, as a child, if I experience a medical emergency where I'm in excruciating pain or my life is threatened, so I'm going through and I'm battling cancer, something like that, a loss of a parent through death, that seems like an obvious one here as well. But we're seeing that especially some more things within this household dysfunction. I would imagine if a revised AIDS survey comes out, I think we'll see slightly different. But these are the historical ones that led to that initial finding. Here's one thing that blew us away. And this was, I think if the AIDS study did one thing, it showed us that trauma is in every community, and it's there in a significant way. And again, if you think about these initial participants, highly educated, again, getting middle, upper class for the most part in San Diego, California. I've been to San Diego a few times. It's a great place. I'm not sure how you can be sad in San Diego. It's sunny and 75. Though I know they work with folks that are struggling down there as well. But, you know, what we saw was that about 2/3 of folks had experienced at least one adverse childhood experience. And so this showed us that trauma was much more prevalent than we ever thought it was. It was kind of something that happened over there, not next door to me, not in my neighborhood, that sort of mentality. And what we realized was, yeah, it is really everywhere. I like to people, a good way for me to visualize this, if you think about a high school graduation and you think about folks going up there, the kids, those educated, beautiful brains going up there and getting their diploma, what research shows us is about in the average school, about 2/3 of those kids have experienced trauma in their life already. And now we also know that those kids that have experienced a lot of ACEs might not be at that graduation because we know they struggle more academically, but it's just a good way to think about it, is that pretty much any school across the country, that's the prevalence of trauma that we would see in that population. Again, really opened up our eyes. Now, when we talk about this from a public health and a medical perspective, there's two chemicals that really help me understand the impact and the chemical response to trauma and its detrimental causes long term. And this is cortisol and these inflammatory cytokines, that work with our body and really play a positive role and also a negative role. So when we look at cortisol, cortisol is great when we need to run away from something or fight back. Basically, throughout most of human history until very recently, we had to have a physical reaction to stress. Either something was causing us danger, or we just had to get something done. And for most of us, that meant doing something physically. We didn't have email. We didn't have telephone. And so stress was a call to physical action. And cortisol is great for that. It gets us up off of our butt and gets us moving. It gets us working and reacting to the stress. Cortisol is also, as most things are with the brain, a pretty complex chemical. It's really easy to just say, oh, you know, if a tiger's chasing you, it just throws the energy out of your brain and puts you in your arms and legs so you can run faster. That's the easy definition and the traditional way that we looked at this stress hormone. But we also know that cortisol helps us reestablish our regulation when the stress is passed, too. And so there's been some interesting studies coming out in the last few years where we seem to show that high levels of cortisol are not healthy for us over time. But folks that have experienced trauma can also have abnormally low levels of cortisol as well. And this is also throws our other systems off whack. Now, again, they will still get flooded with cortisol when they're confronted with stress, but there seems to be one way or the other this dysregulation of cortisol within our body. And so cortisol, again, on the positive side, brings us to action and gets us moving. On the negative side, we'll talk about some of the other consequences. The cytokines, on the other hand, are really interesting chemicals as well. And so these, on a positive note, if we get sick, if there's a virus within our system, this really starts to go out and destroy those things. So they're the protectors of our immune system. And when we have damaged tissue, it helps to repair that tissue. So again, this in a non-traumatized environment, biological environment, really helps us fight off illness, fight off disease. You know, for those of us who work in the HIV arena, we're kind of familiar with this, with the life cycle of HIV and those things. So short term, these are both good. They keep us healthy. They keep us alive. If we didn't have these two chemicals, we would not be alive as a human race. They keep us healthy, and they allow us to react to stress. However, in the long term, here's where we get in trouble with these two things. So cortisol, there's a lot of research coming out. Some people are starting to call this lowercase trauma. So it's something that's not really something like an adverse childhood experience where you could say, this happened last Tuesday, a big event, and somebody is now traumatized because they experienced that piece. But what we know is that if we grow up in stressful situations, so let's say maybe it's a home life where there's no physical violence, there's no maybe severe mental health or incarceration or substance abuse, but every night when the kid goes to bed, mom and dad have a really verbal fight with one another over something. Maybe a kid in the south side of Chicago has to, or other communities across the country has to hear gunshots as they go to sleep every night, and they don't feel safe in their own neighborhood. And so what we're seeing with this sort of concept of lowercase trauma, trauma with a small t, so to speak, as some people say, is that things like poverty, homelessness, dysfunctional families, there's this constant flow of cortisol being released into our system. And this really, as we talk about sympathetic versus parasympathetic nervous system, really decreases our ability to live an emotionally regulated, cognitively engaged life. And so when we talk about the sympathetic nervous system and the parasympathetic nervous system, you can think about it in a very simple way. The sympathetic nervous system is that fight or flight response. We'll talk a little bit more about that in an upcoming slide. But that's the fight or flight response. And really, that's always ready to take hold. So if the person sitting next to you spontaneously combusts, you're going to have a reaction to it, right? You're either going to go get some water to try to put them out or just run out of the building screaming because you're freaking out. So we've always got this sympathetic nervous system ready to take over. If a meteor crashes into your clinic, you're ready to take action. And that, for all of us, will happen in a split second. Now, what the parasympathetic nervous system does is it acts like a brake. And so what it does is that it keeps the sympathetic nervous system under control. So hopefully right now there's no meteors crashing through your clinic. Nobody's bursting into flames around you. So your sympathetic nervous system is quieting that fight or flight response. And this allows information to go down that thinking road into the cortex, prefrontal cortex, so you can really listen and engage with the subject that we're talking about today. So what we see when there's that low release of cortisol or levels of cortisol released by traumatic experience is that parasympathetic brake starts to weaken. And if trauma happens over and over, and this is happening in the terms of a dysfunctional maybe family relationship, a dangerous neighborhood or community situation, we see these a lot with refugees coming out of war-torn countries where there's just this constant threat, is that it's better for that brake to get weakened, if not pull back altogether. And so people can be really just living in that sympathetic nervous system. This is, I mentioned last time with my wife, what she calls that amygdala fight or flight response is the lizard brain, is what she uses with her first graders. And if you've seen a lizard lately, they're always kind of looking out for the next threat in the environment. And so we see that can take over under this constant release of cortisol. Also, we know that cortisol, while it's good in the short term, if it stays in our body, if we don't have that physical reaction to it, it becomes toxic. And we'll look at the medical results of this toxicity, because it really starts to damage all the systems and throw off all the systems in our body, which again, if we have that consistent release over time, can be very detrimental. On the other hand, the cytokines, they will eventually, if they're not, if there's more release than necessary, and again, these are also released when we're stressed out. And so if there's more, these are released constantly over time, instead of repairing tissues, the cytokines will start to damage the tissues, basically resulting in inflammation. And so this can happen all over our body, and including, we now know, in our brain as well. And inflammation does a couple of really negative things, especially if it happens and stays with us in a long-term basis. So one of the things it does is, because of the damage to the tissue throughout our body, it opens up the opportunities for diseases to take hold. Basically what we see with trauma is there's high damage to the immune system, especially trauma coupled by that low T or trauma where there's all this stress that continues in the environment. And so over time what we see is that the cytokines are released, damaging tissue, opens up the availability for that disease to walk in. The other thing that I'm really, and I don't have a study right now to point to, and if anybody does, I'd love it, or if I'm just wrong, please tell me, email me, tell me I'm wrong. But what I seem to also be seeing evolving out of this research too is that we know that cytokines really increase the symptoms that we experience. So we might have irritable bowel syndrome, but with the cytokines released, we're going to experience that in a much greater way than if we were able to live a less stressful existence. And I just got, when I started to read this research, I know a lot of us spend a lot of time thinking about those high utilizers of medical services, the people that show up in the emergency room, sometimes multiple times during the week, the $1 million+ a year patients that we all pay a lot of attention to, and for good reason. And I started to wonder as I saw this escalation of symptoms is how much of these folks showing up into emergent care, obviously not in the clinics like we want them to, is a result because they're experiencing their symptoms in such an escalated way. And when they walk in, the physician, the medical providers may not understand why they're there because their symptoms, again, their condition might not, in their eyes, justify emergency room care, but the experience of the patient might seem like it's a life and death thing. The pain can be more extreme. The symptoms can feel more extreme, whether that's headaches that turn into migraines, again, pain that turns into chronic pain and severe pain. So we're starting to see this connection emerge. And again, so these two things that are released during trauma, whether that's a big T trauma where they flood our system, or just that continuous sort of mild flooding that happens in life of stress, we start to see how these chemicals, good in the short term, are devastating in the long term. I like to bring up, and if you've heard me present, you've probably heard the cup analogy before, but I want to bring this in with these two chemicals because I think it furthers our understanding of this. And I use this cup analogy. One is it's a good way for me to understand some of this science in a real practical way, and I've also really encouraged people, because I've got a lot of good feedback, is that they can use this with their patients and clients as well. And it's a really easy way to understand the impact of stress is having on our body. So the cup analogy has two different parts. The first is what I like to call robustness capacity. And robustness is really that we have the energy to really live the life that we want to live. And so what we know is that the size of the cup is really looking at the amount of stress that we can hold, the cytokines, the cortisol, without sort of losing our bleep on somebody, right? We've all been in those hard days. If one more person looks at me in that way, I'm just going to lose my bleep. And so this is why a large capacity or a bigger size cup allows us to hold more stress without getting into that sort of fight or flight mentality. So what is robustness capacity increased by? Basically, living a healthy life, having people in our life that love and care about us, being able to eat healthy, exercise. One of the things we know is overcoming trauma can build to increased capacity. If I was able to overcome one hard thing, I've got that energy that I can rely on to overcome other hard things or just deal with day in and day out stress. So that self-confidence also really helps. And what it's decreased by is, again, unhealthy lifestyle. What really breaks my heart is just a lot of our folks and folks that I've worked with just can't afford great food, right? They can't afford good organic fresh vegetables. And I think we've done a better job at this. But, man, I still go through a lot of neighborhoods around this country, and it's a Rite Aid or a 7-Eleven are a lot of our folks' food choices if they're lucky enough to have enough money to even get food. And so a lot of the things that they would need to really better handle stress, like a good night's sleep, healthy food. I know this even sounds like a joke, but exercise on a regular basis, connection to healthy people, those sort of things, unfortunately, with homelessness are often not there. Also, what wears down the capacity or size of the cup are things like addiction, trauma, and long-term intense stress. So that basically, if you think about this, the size of the cup can be equated to that parasympathetic brake. So the brake that keeps the fight or flight response at bay and allows us to engage in the world in a cognitively and an emotionally regulated way. So the bigger the cup, the stronger the brake. The smaller the cup, the weaker the brake, and the more likely I'm going to get in the fight or flight response. So let's throw this back. This is the brain that we talked about last time, where stimulus, especially from hearing and visual, go into the thalamus. And again, that's where the decision is made of whether or not something is a threat. So again, as we look at robustness capacity in this analogy, the bigger the cup, the more likely we're able to process that information up to that B road, the high road, the long road, what my wife calls the wizard brain, goes up there through the cortex. It relates it to all the memories that they've experienced in the past. So with that context of memories, it throws the stimulus into the prefrontal cortex where we can strategically think about it. Then it shifts it down in the amygdala where it gives it an emotional context. And so, again, all this happens within fractions of a second and is continuously going along as long as that brake is on. Now, again, if that brake's released, it goes down the amygdala. This triggers what's called the HPA axis response. The hypothalamus, adrenal gland, pineal gland, all floods, that's where those chemicals are released and floods our system. And so this is what's called the limbic system. And so this is, again, when we looked at the traumatized brain last week, this is overdeveloped, meaning that that parasympathetic brake is unfortunately weaker. So again, I'm going to have more of that reaction to stress. Now, when we talk about the cup analogy, there's also the level of water, or you may have heard the allostatic load concept in your own reading. This is really when stress becomes dangerous to our own health and well-being, where we all need a little stress in our life. A little stress is good. This is what some people call eustress. And so to have some stress in our cup, because we want to have a little stress about getting to work on time, doing a good job, showing up, being a good mom, being a good dad, whatever our roles are. You know, stress helps drive us to be our best selves in some way. So a little stress will always be in our cup, and that's not always bad. But this load describes when stress becomes harmful to our system. Now, as we look at this, what increases the size of the level in our cup, and the more water in our cup, the less ability, again, we have to engage cognitively and emotionally in the world, and we'll talk about that here in a second. But what fills our cup up quicker are three key things, and boy, when I think about homelessness, this almost is a definition of homelessness, unfortunately, for a lot of people. So one, if things go on for long periods of time, and so this brings into the science that small t trauma language about I'm just growing up in family dysfunction. It may not be necessarily traumatizing, but every night when I go to bed, or at least most nights I'm hearing my parents argue, I don't feel safe when I walk to school. It might not be traumatizing, but again, there's all this stress going on. I believe folks experiencing homelessness, if you've been chronically on the streets for the last 2 decades, waking up on the streets is probably not traumatic within itself as far as an event's concerned, because that's been your reality, though every day you wake up and you've got to survive. And that can take its toll in a very real way. So things that go on day after day after day that are negative in our lives will increase the amount of water in our cup. Whether or not something is important also will increase the water going into our cup. So if you think about, again, what we're talking about with homelessness a lot of times, we're talking about basic needs of survival, of safety. When you think of Maslow's hierarchy, of whether or not I'll get a meal today, whether or not I'll get a shelter bed this evening, those sort of things. So we're talking about the struggles of homelessness, our survival struggles, and there's really nothing more important as far as our brain is concerned than surviving the day in front of us. And the final piece, which I also think is connects to homelessness in such a tragic way, is uncertainty. Whether or not I'll get a bed or not, whether or not if I go to sleep in the park, somebody will steal all of my stuff. And so there's a high level of uncertainty. So again, when we start to think about folks that we're working with, a lot of them, because of life situations, have a small capacity, again, a small size of a cup, and then that cup just gets filled day after day after day after day. And this really helped me start to understand some of the behaviors that sort of mystified me early on in my career. Hyperstress is basically that stress stays in our cup, that we're not able to get it out in a meaningful way. We call this burnout in the work environment. It's not that I just have a constantly high level of stress that even when I go to bed, I wake up with that sort of same level of stress in my cup. And so this is a real continuous thing when we talk about the impact of living in very stressful situations long term. Trauma, in this analogy, I like thinking about trauma as you're basically dumping that cup into a bucket of stress. And the stress just overwhelms all of our capacity, and we're sort of lost in that bucket of stress. Passive trauma is when nobody comes along to help us out of there. I like to think about the visual of what we need to recover from trauma. We'll talk about a lot of this in the final webinar, is somebody to reach down and help us out. Again, not reach down and save us, but reach down, work with us, and help us get out of this emotional mess that we're in with past trauma, pain, and suffering. And complex trauma that we talked about. This is repeated trauma over time, growing up in a home with domestic violence, addiction, high levels of family dysfunction, struggling families or communities. So this is just adding more and more water to that bucket, making the journey to post-traumatic growth that much more difficult. Unresolved trauma, we talked about re-traumatization last time, and this is really those traumatic memories that I haven't really been able to work through yet in a therapeutic situation. And those memories just stay in my cup, and I like to think about them as rocks in the cup. They really limit capacity, but also if a certain stress or stimulus in the environment reminds me of my past trauma, what's going to happen is that rock is going to explode. And so that brings back all those memories of my past trauma into the present moment. So again, this cup analogy, the size of the cup really is our capacity. The bigger the cup, the more stress within our day, whether that's stress just from day-to-day activities or from, those small T traumas that we're talking about. And then the water in our cup basically determines how big this concept of our window of tolerance is. So I like to think about our window of tolerance as the distance between the level in our cup and the top of the cup. And if we have some significant room, what we're able to do, again, is put on that parasympathetic brake and get the information, the stimulus, and do that prefrontal cortex. Daniel Siegel, who's done a lot of great work around this, says when we're in our window of tolerance, we're flexible, adaptive, coherent, energized, and stable. And he uses these words to describe prefrontal cortex functioning. And I thought about a lot of the folks that I worked with when I first read Siegel's work. And I looked at, okay, flexibility. Are they flexible? And for so many of our folks, they weren't. Basically, if things didn't go exactly how they wanted or needed them to go, I was often met with a great deal of frustration, depression, or sometimes even outright anger. And so there wasn't sort of the ability to kind of roll with just what was changing in the environment. It had to sort of be an all or nothing game. Adaptive, I think the greatest example of this I hear is with housing providers, especially in housing first programs where, we're able to get these folks into housing situations, and we visit them a few weeks later, and what we find out is that they're storing their clothes in the apartment, their stuff in the apartment, but at the same time, they're going and they're still sleeping out on the streets. And so we see that it takes a long time for folks that are under this high level of stress to really adapt. What that person is struggling with is, I have a brain designed to really thrive out on the streets, or survive at least out on the street. You put me in a quiet place by myself, and I have no capacity to really hold that experience. And it can freak me out, and I can actually feel safer sleeping out as I've done for the last 20 years. Again, with time, this is why resources plus support is so critical, because with a little support, this change usually can happen gradually over time for everybody. Coherence, one of the things that we know with trauma, especially extreme trauma, is something called disassociation can happen. And disassociation is kind of like checking out. You kind of lose touch with what's going on around you. In extreme cases, this can be diagnosed as dissociative personality disorder, or what we used to call multiple personality disorders, where we almost form different personalities to handle extreme stress. While this is not the majority of people any of us work with, especially with chronic homelessness and addiction, histories of especially sexual or physical abuse, you can see this from time to time. One of the indicators of this is when people have really escalated behaviors and you check in with them a week later and they don't seem to remember that event at all. And it's really hardwired into your mind because it was an intense, extreme event, but yet they don't seem to remember it. I thought with the kids I worked with, they were just pulling my leg on this stuff, but we know now with the sciences I can disassociate, and I may not even form memories that I can pull back later on. So a lot of complex stuff there, but coherent is really being the same person day in and day out, whether you're stressed out or not. And again, we know that that's not always the case for some of our folks. energized, really having that robustness to engage in life. Again, I saw that a lot, very quickly my folks could become overwhelmed, didn't seem to have the overall energy really to live the life that they wanted or go through all the hoops we put up for them that they had to jump through. And then stability, where it's not like an emotional roller coaster of life. And so when I looked at these things, when I looked at the faces, and I looked at the folks I was working with, I just realized none of these really represented the majority of folks that I was working with. And I started to ask the question, when the cup analogy came to my mind, I would ask the question, where's your cup today? And I give them a little basis of the science, more of just, when you get stressed out, your cup fills up. And when it gets to the top, then you go in that fight or flight mentality. So I would just give them kind of the basic outlines. And about 95% plus of people that I saw said, hey, my cup is full. And that made me really like, oh, well, that's why I don't see flexibility, adaptive, coherent, energized, and stable. They could identify in themselves that they were just one stress away from losing it. And when I started to ask these questions, it gave me a lot of insight into behavior. So as our cup starts to fill up, we usually react in one or two ways, and these are designed to gain some control over the environment we're in. The first response is rigidity, and rigidity is a good response if you have control over things in your environment. And so I like to say I'm a rigid responder, and it manifests itself in me and in a lot of people as perfectionism, that I want to really give them the best of myself every presentation I do. This has driven me to a few degrees in school. It's really, in many ways, served me well, though sometimes it drives everybody around me nuts because I'm so anxious about stuff. But for the most part, I had some success, and I built upon that success. What we know, a lot of our folks also are perfectionistic, but it manifests itself in a real tragic way. And I think this is really important for, as we talk about healthcare engagement, is that if I have this perfectionistic drive, this rigid response to stress, and then I get into school, and I try and I try and I try, but I never succeed. So I might study my butt off, I might work my hardest on a homework assignment, but my grades continue to be terrible. And so for so many folks, instead of doing their best and failing one more time, and I think I see this manifest itself in programs all the time, instead of giving my all to try to do my best, it's easier for me just to give up because I can't fail one more time. And so, again, I think that a lot of times when we talk about trying to, especially in my work in HIV, we dwell so much on adherence, and we have to because of resistance. I totally understand that. But at the same time, if they haven't taken their medication as they know they need to, sometimes it's easier to not show up for the appointment than to get one more lecture from the doctor about the necessary of adherence. So we see this can have negative impacts. Chaos is a response I saw a lot more of. I often tell, if you've heard me talk about this, one of my kids early on in my career was doing really good. He was, I was working with gang members at the time. He was really thriving, and we were going to get him into college. And I needed to bring him he needed to bring me some paperwork so I could get him into these programs. And he forgets one of the pieces of paperwork, and you could just tell he just lost it. And he blows up, calls me all these names about, a big incident in the program. And luckily enough, he calls me back, apologizes, brings the piece of paperwork in. And I asked him, okay, what happened here? If somebody was trying to help me out. Like I'm trying to help you out, getting you into school, helping you get away from all that trauma back in your community. What happened here? And what his words described, I think, were so dead on with the chaos response and just opened my eyes up to a lot of other behaviors. What he said was, when I get stressed out, and there's a lot of stress in my life right now, I have learned over time, and these were his words, when I act a fool, y'all leave me alone. You back up and you give me some space. And so what he found out, and this kid could get all puffed up and what he called gangsta on us, we gave him space. We backed up. Now, ideally what we would want him to say was, hey, listen, my cup's getting full. Maybe if you give me a few minutes to take some mindful deep breaths, and think about my long-term goals and objectives on my service plan, and maybe even run around the facility one time to get some of the cortisol out of my cup, I could come back here and engage with you about long-term planning for my future, right? But we know that trauma, unfortunately, really, and let's face it, a lot of us don't have that sort of insight within ourselves. But what trauma does, unfortunately, it damages what's called the Broca area. So language it's basically used more as a wall to protect us than something that allows us to express what's going on with us emotionally or intellectually. And so this chaos response, even though I've seen so many people, and I'm guilty of it myself, get kicked out of programs, this behavior gets people arrested. What it is I can't verbalize the pain, the hurt, the fear that I'm feeling, so it manifests itself in some pretty chaotic behaviors. So as our cup starts to fill up, this is where we go. We either try to gain control over our environment as much as we can, or there's this chaotic response with the goal to get us some space. If this doesn't work, then we usually activate the fight or flight response. We've already talked about this. This is that sympathetic nervous system. In other words, the brakes fully released. And this really, again, we usually run away first from what's causing us stress. That's usually the safest reaction, is to get as far away from the stress as possible. It's sort of the chaos response, but instead of behavior, it's sort of physical running away. I think in the healthcare setting, it means sometimes not showing up for appointments, just not coming can be a sign that the cup is pretty full. If we can't run away from the stress, we will often strike out of what's causing us stress if we can't escape. I see this when I talk to HCH medical providers, is that there's something for a lot of clients, especially, or for patients that folks don't know, something seems to be triggered as that door shut. And now I'm in an isolated room with somebody I may not know, and that triggers this response. And because the door's shut, I don't think I can escape, and sometimes that can lead to violent behavior. So this could be the fight response. It's usually when we can't see that we can escape. The final response is the freeze response, and this is where dissociation happens as well. We become disconnected in some way from the environment. And usually this is the final response, but for victims especially of sexual abuse and physical abuse, especially in childhood, most folks had no physical power, social power, economic power to escape that abuse. So if it happened over time, they had to shut down to survive. And so, again, this is, if I'm stressed out and disconnect, this doesn't fare well for a lot of folks with engagement and those sort of things. But it's just a survival response when the world gets too intense. So I want to talk a little bit here as we sort of get to the end of our time together about some of the impacts and leading indicators that we see in the research. I could give a whole day training on trauma and mental health, but boy, does this quote sum it up. If child abuse and neglect were to disappear, the DSM, or Diagnostic and Statistical Manual, which if you're not familiar with that, it basically has 300 diagnoses and about 1,000 pages long of mental health disorders, would shrink to the size of a pamphlet, and prisons would be empty in 2 generations. I think that's an incredibly powerful statement that I could spend a whole day backing up with research. We know that so much of the mental health issues we see stem from past unresolved trauma. Not all of it. There would still be that pamphlet there, as he's describing, but the vast majority we can see relating back to that past trauma. Here's a slide that is still shocking to me to put up, and these are correlated health issues that are, whether it's the age study or other trauma studies, that we see trauma dramatically increase the likelihood for things like heart attacks, MS, obesity. We talked about the autoimmune disease issues, cancer, diabetes, headache, ulcers, chronic fatigue, liver disease. You could put chronic pain in there. This is probably one of 3 slides if I went through them all. But this really opened up when we talk about those cytokines opening up the window for potential diseases. This is the result of that if that stress level remains high over a long period of time. So when we talk about trauma being the public health issue of our time, and then you look at what a history of trauma opens you up to in a much greater way, again, this is just really eye-opening, even for me who talks and thinks about trauma so much of my professional life. At the big top of that pyramid, here's what we see. If somebody has 6 or more ACEs, their life expectancy is 20 years less than somebody with no adverse childhood experiences. From age 80 for somebody with none to age 60 with somebody with 6 or more. So a loss of 20 years of their life. And now 6 might seem huge, but I want to just make this, especially for folks that end up in, again, shelter systems, criminal justice systems, substance abuse addiction, why 6 isn't all that much when you start to look at household dysfunction. So let's just say within the household that there's domestic violence exists. Let's just use the typical thing of dad abuses mom and that tragic situation. And the child grows up in an environment where domestic violence is present on a weekly basis. If dad is hurting mom, I'd say there's a better chance than not that there's at least some physical and emotional abuse, if not sexual abuse, going on with the child. Maybe not sexual abuse, but I'd say definitely emotional abuse, and physical abuse is more likely as well. So right there we could say if this is happening, there's probably some kind of abuse going on with the child. So there we have 2. Is there neglect? I would say probably some emotional neglect, at least if this is the reality that a kid's going up with. So there we have 3. Is either the result of the domestic violence, the mom experiencing mental illness, or is that mental illness causing the domestic violence or contributing to it? I would say yes to one of those. So, there pretty quickly we're up to 4. Does substance abuse play a key role in this? Potentially. And I think you could look at of these 3, substance abuse, does that ever end up in jail? Do the neighbors call the police? Is there criminal justice involvement? And do mom and dad eventually get divorced? So you can see how this household dysfunction can really lead quickly to getting these scores of 6 or more. And as we talk about a public health issue, just think about things in our reality that are shown to take away 20 years off somebody's life. There are things that do that, obviously. And a lot of those, unfortunately, are also the diseases that we see connected with experience of past childhood trauma. So when we look at this pyramid, what we really want to make sure, and this is where I see the paradigm shift really happening, is we can just focus on the behaviors and the symptoms, whether these are real symptoms of the behavioral symptoms of mental illness, the medical symptoms of all those diseases and conditions we covered, and we can really get stuck in the behaviors of what did you do. And for a lot of the symptoms of trauma, which in some ways include potential struggles with homelessness, addiction, so on and so forth, it's easy for us to get stuck up here. And this is really the paradigm, especially in our modern criminal justice system in our country, this is the paradigm we're really stuck at. And so as long as we're up here, we really miss these opportunities for wellness. Dr. Filiti here, really one of the founders of the ACE study, one of the principal investigators early on, has a great quote from the medical side on this. And he says, it's easier to respond to the symptoms that a patient is presenting in the moment than it is to understand why the problem exists in the first place, especially if the problem is chronic. But when physicians seek to understand people's lives, as well as the biomedical bodies and symptoms, we create new possibilities for patients to find wellness. And that to find wellness, really, I know it's a lot of our goal in this. And so really looking at this and at this paradigm shift of how we help people really heal. It's just a little bit more justification here. What we know, these numbers blew me away a little bit, and I put the zeros in so we were reminded what a billion really looks like. And so we now know that the total lifetime cost of child maltreatment, so that abuse, that neglect, is $124 billion annually. And I put this out here because if we say we don't have enough money for mental health services, we don't have enough money for substance abuse services, we don't have enough money to really get kids in schools the medical and mental health services that they need. If we don't have the money to help struggling families really not experience homelessness, if we don't have the money for Housing First programs, what about this cost? And again, we look down this at the individual level, and we can see the individual impact over a lifetime as well. Now, we may not be able to take all this $200,000 away, but what if we intervene early enough with a kid in a school and get them the help that they need to recover from that trauma? That's going to cost a little bit more than we're currently spending. It's not going to cost $200,000 over the span of their life. So if we can get people, there's a lot of money to be saved, and there's a lot of pain that we can stop. And so again, if we want, looking for that financial justification for this, here it really is. So our goal with all this is to take this old paradigm of focusing on behaviors, focusing on presenting problems, focusing on symptoms, and making sure that at least in measures, but we also put a strong focus on this underlying neurodevelopment and making sure we understand what happened to this person, not just looking at them as a set of symptoms, but really what happened to them. And if we can assess and we can identify that they've experienced childhood trauma, then what services can we give to help them heal and grow from that? How do we help them get ready for mental health, substance abuse treatment? Those sort of key things that we can do. One really good leading study that's come out lately is, and this is in traditional healthcare settings, not specifically in healthcare for the homeless settings, but I thought this was really powerful when I saw this, is that doctors who have patients in the waiting room fill out the Adverse Childhood Experience Survey, and then they ask the follow-up question. If somebody has an ACE score of 1 or more, they ask the simple follow-up question is, how do you think this past suffering is impacting you in the present? Just asking that question and having a brief conversation. This is, they still only have the 15, 20 minutes or less for the visit, but just that simple question, when that's brought up, we see a 35% reduction in medical visits and 11% reduction in ER visits for these patients. I just, again, these are leading indicators of the power of having some of these discussions in a medical setting. My final thing before we get to the Q&A here is a call to action. One is, I challenge you when you go back and you think about this and what does this mean for us in our program, really thinking about how do you assess for trauma? If you bought in to my brief opportunity to show you some research around the impact of trauma on health issues, I think you see it's important for us to make sure that we're assessing and discussing this with patients. I want to throw out there that this can be difficult because we already put our patients sometimes through a lot of intake assessments, diagnostics, depression scales, all these things. So to add another questionnaire on there, whether it's the ACE study, the life events checklist, whatever we might use, has the possibility to re-traumatize somebody, especially if we don't have a strong relationship already built up. But I think this is a struggle that we need to talk about, is, that there could be a cost, and it doesn't mean we have to do the Adverse Childhood Experience Survey right when they're a new patient. We can wait a while. We can build a relationship. We can build safety. Maybe this is done more by the case manager than the physician. Maybe it does make sense for the physician, nurse practitioner, PA to do it. But having these discussions, if this is shown to be the cause of all these other health problems, how do we identify that and help get somebody the treatment they need, knowing that, again, there can be a lot of work done to get them feeling comfortable with mental health services. The final piece, and this is a piece of inspiration for me this week, is how can you help rally community partners around discussions of trauma? I had a great example of this week. I was lucky enough to go to Pasadena, California, and a clinic there that focuses on children called Young and Healthy had organized their community and to become trauma-informed. And so this training led off by their great leader, Mary, saying, today's the day we start changing Pasadena and eventually changing the world. And so there was this group of principals, nurses, occupational therapists, art therapists, the library was there. There was all these different providers from mental health, from substance abuse, a room probably packed with about 125 plus people. They're ready to go. I've never really got the ready to go so strong. They just needed a little bit of direction from me about a little bit more learning and understanding, but they were ready to go. And I think that's a great example of a medical provider using sort of their status in the community as physicians, as nurses, as they obviously there's mental health, substance abuse, all those things put in, but to really start to organize a movement around this topic. And when I think medical professionals go to principals, library staff out in the community and say, we're seeing a huge medical impact due to this past suffering and trauma that's in our community, I think that it opens up doors that might be closed otherwise. So again, I see HCH providers being in a real ideal position to start to organize communities to really talk about this at a much larger level, to partner with schools, to partner with libraries, to partner with other providers in the community, and really state, okay, how do we become trauma-informed, giving us a better understanding of those experiencing homelessness, hopefully, as we talked about last week, stopping those pipelines to homelessness, and really increasing the overall health and well-being to our community. So with that, I want to thank you guys so much for your time, and I want to just turn it back over, and we'll kick around some questions.
Great. Thanks so much, Matt. We currently do not yet have any questions entered in. If you do have questions that you'd like to ask Matt, please go ahead and enter them into the chat box now. In the meantime, Matt, do you have any final points you'd like to make?
You know, I have points, you know that. You know, I would just say as we look at this information, and especially since I have an additional second, I want to pull back because I think it's this slide that really impacts me, is that if we understand the biology, that the impact of constant release of cortisol, of the cytokines, these things and their impact on our system, it starts to really break down what have these been kind of traditional barriers between mental health and medical health. And I think that it hopefully, with a lot of help from us, we can start to destigmatize the mental health side of that equation. And I think this is the role with you all being medical providers is so very important, is that if we can really start to take this information into our community and saying, you know, we know that we're having a lot of negative health outcomes for our kids and our adults because we haven't given them a chance. We currently don't have the systems to really deal with childhood trauma. Throwing up a slide like this hopefully gets people thinking and understanding the importance, and again, of that long-term cost as well.
Great. Thank you, Matt. Well, as we don't have any questions submitted, I'd like to thank you all for joining today's webinar. A link to the archived webinar and the PowerPoint slides will be emailed to all registrants within a few days. At the close of this webinar, an online survey to evaluate it will automatically open in your web browser. Please do take a moment to complete it to help us improve your webinar experience. Part 3 in this series, The Abyss, Addiction, Homelessness, and Trauma, will be presented on Wednesday, October 26th at 3 p.m. Eastern Time. Please see our website, www.nhchc.org, for more information. Thank you, and this meeting will now be closed.